clinical practice, advanced programs of education, and to promote ethical standards for clinical care and scientific investigation. Before we begin, may I take this opportunity to welcome the President of the Indian Society of Organ Transplantation, Dr. Jayaprakash Oja, Secretary Dr. Vivek Balakrishna Kute, and Treasurer Dr. Narayan Prasad. ISOT 2021 takes immense pleasure in inviting you to the 31st Annual Conference of the Indian Society of Organ Transplantation, held at Hotel Grand Hyatt at Kochi, Kerala, India, a venue of international standards. These days are bound to be surplus with an academic fiesta, and the organizing committee has left no stones unturned and promises that you return abounding with new knowledge and the recent advances in organ transplantation. We are fortunate to have renowned experts across the globe as speakers with a wide range of topics. This conference will also give you an opportunity to interact with experts in the field. Introducing to you the Organizing Committee of ISOT 2021, Dr. Ebi Abraham M., the Organizing Chairman, Dr. Rajesh R. Nair, the Organizing Secretary, and Dr. Maman M. John, the Treasurer. Without further delay, let's move on to the scientific sessions of the third day of the 31st Annual Conference of Indian Society of Organ Transplantation, ISOT 2021. Please note, specific timings have been allotted to each of the sessions. Kindly request the speakers to stick to the timings and also requesting the chairpersons to ensure the same. This is for the smooth conduct of the program, requesting your cooperation for the same. Let's begin with the scientific sessions of the day. The first talk on Astellas Industry Symposium, Modifiable Risk Factors and Once-a-Day Tacrolimus in Kidney Transplant. May I invite the speaker, Dr. Nas Undre. I also invite the chairpersons for this talk, Dr. Rajan Ravichandran, Dr. T.T. Paul, and Dr. Srijit Parameshwaran. Dr. Nas, we also have a recorded session of you. Would you like to proceed with the recorded session, or are you planning to go for a slide sharing?
I'll slide share.
Okay, sure.
I think you can go ahead and start, sir.
Yeah, go ahead. I'll do that now. Thank you.
Yes, sir. Your slides are visible. You may proceed.
Thank you very much. So I'd like to first of all thank the organizers for very kind invitation and for Astellas for sponsoring this. My talk today is about modifiable risk factors and benefits of once-daily tacrolimus in kidney transplantation. This is general disclaimer for the presentation, and this is my conflict of interest slide. Okay, so the presentation overview is that tacrolimus is a cornerstone of immunosuppressive therapy. We know that approximately 90% of the transplant recipients are treated with tacrolimus-based regimen. It is classified as an error therapy index medication, and we'll discuss what it means and what is the clinical relevance. For patients with end-stage renal disease, we know that transplantation is cost-effective, and one-year graft patient survival have really gradually improved over time. However, we do see a decline in graft survival in the longer term. And there are multitude of reasons for that. And some of them are modifiable and some of them are not. And the modifiable factors that we will discuss today are the intrapatient variability and non-adherence, and how do we manage and minimize the risk. We also have to discuss about impaired immunity as a risk factor for critical outcome in transplant patients with COVID-19. We are living through this phase. How can we manage immunosuppression in such patients? How does that affect the modifiable risk factors? Tacrolimus is also available in multiple formulations. Do formulations matter? How do you manage multiple formulation in clinical practice? Are now all formulation interchangeable? I'll discuss what I mean by interchangeable as we go along. Then we also discussed the prolonged release tacrolimus, which is administered once daily. I call it once daily tacrolimus formulation is developed to minimize the effects of some of the modifiable risk factors, and we'll discuss the clinical benefits of prolonged release tacrolimus. So these data are a proof that whether we look at liver or kidney transplantation, approximately 90% or more of the transplant patients are today in current clinical practice received a tacrolimus-based regimen. It is the more preferred of the two CNIs, and these data are from the OPTN registry data as of January 2020. So, tacrolimus is classified as narrow therapeutic index medication. The question is, what does it actually mean? And there's often discussion about in the literature what is meant by narrow therapeutic index medication. However, it is better to understand from a regulatory perspective. So if you look at the European Medicines Agency or the Health Canada definition, they have actually defined what a narrow therapeutic index medication is. So it is a drug where risk of clinically relevant differences in efficacy and safety between two different formulations are apparent even when those formulations are conventionally bioequivalent to each other. There is steep concentration response relationship in efficacy and toxicity of both. And generally, we individualize the dose either based on the basis of plasma concentration monitoring or according to clinical response. For example, warfarin, we would measure clinical response in order to manage patients on a particular level of exposure. And the potential for serious consequences if the drug exposure is too high or too low. Health Canada defines such drugs as critical dose drugs, and these drugs are defined as those where even small differences in dose or concentration can lead to serious therapy failures and/or serious adverse events. Now, the list that we talk about is very limited. We have digoxin, flecainide, lithium, and all, etc. And on that, you add the two calcium inhibitors, which is cyclosporine and tacrolimus. And these are the only drugs which are recognized by the regulatory bodies as truly narrow therapeutic index medications. Well, how do we define that in terms of exposure then? So if we go back to try and understand what drives the efficacy and safety, then the efficacy of tacrolimus and its safety is related to what is known as area under the concentration time profile, which is the shaded area. So when we give the dose, the concentration increase and then decline over 24 or 12 hour or the dosage interval, and that the shaded area therefore defines the area under the concentration time profile, AUC, peak concentration Cmax, and at the end of the dosing interval is very much the trough level. Now, for tacrolimus over a 12-hour dosing interval, if you look at twice daily tacrolimus, then you need an AUC of more than 150, okay? Which is approximately equivalent to 10 nanograms per ml. Now, no efficacy or safety variability is associated with Cmax. So that is not a correlate which affects it. It's AUC related. Subsequent to that study, there was also work done by Professor De Kuipers. This is in Belgium and Leuven, where they looked at both the effect of AUC of tacrolimus and AUC of MPA, and found that AUC of tacrolimus of greater than 150 is again associated with the least amount of acute rejection. But what they also did in this study was to try and see at what point do we overexpose the patients. And one way of looking at it was to try and understand infections in these patients, which were considered to be a marker of overexposure. And in terms of that, you see the difference between too much exposure or adequate exposure is approximately 25%. So, unlike other drugs where the safety margin of narrow therapeutic medication can be up to twofold, for tacrolimus the margin is only 25%. And the infection that took into consideration was occurrence of CMV disease, as herpes zoster infection, etc., etc., etc. So these are the factors that they were looking at to try and understand the difference between optimal and too much. So this is a very narrow safety margin for tacrolimus. Now, how do we manage NTI drugs during COVID-19 pandemic? We've all lived through that, and basically our understanding of many of these drugs has changed and become more apparent. Now, COVID poses significant threat to immunocompromised patients. We know that. Some studies have demonstrated that the high mortality rate in kidney transplantations with COVID-19, and the number of studies on that. And it is now understood that the part of COVID-19 severity is linked to the cytokine storm, which is a disproportionate hyperinflammatory reaction occurring in the infected patients. So in this scenario, immunosuppressive drugs may be clinically useful, i.e., in the scenario of cytokine storm. And does it bear evidential proof of that? So the most well-documented data comes from the European Liver Transplant Registry. There's equivalent data from kidney transplant registry doesn't exist. So, and they evaluated data from 243 adult patients with symptomatic cases across 36 centers in 9 countries, and tried to correlate mortality with various covariates. Now, age clearly became a risk factor, and there was a linear increase in hazard ratio with every 1 year increase in age. Okay, and then if you look at age between 60 and 70 versus under 60, then you had approximately 2-fold higher hazard ratio, both in the univariate as well as multivariate analysis. When you started looking at patients over 70 compared to over 60, then your hazard ratio is between 4.4 to 5.5. Again, in both cases, both univariate, multivariate is highly significant. So age clearly plays a role. But what about the role of immunosuppression? Does that have proportionate or disproportionate response? And here they looked at the effect of individual components of the immunosuppressive therapy. So, for example, cyclosporin versus all others in univariate analysis increased the risk by approximately 2-fold. Mycophenolate mofetil versus others also increased the risk, and the mTORs also. However, in case of the MMF and mTOR, the hazard ratio, although higher, did not reach significance. The outlier in all of this was the tacrolimus. It actually decreased the hazard ratio, both in terms of the univariate model as well as the multivariate model. And in both cases, this was significant. So essentially what you're doing is reducing the risk of mortality by between 45 to 60%. Okay. So the tacrolimus has that effect in terms of protecting. So the guidelines on how to manage patients transplant patients who develop COVID-19 is beginning to be gathered in terms of understanding. So it is suggested that in essence we do not substantially decrease tacrolimus, but start by reducing immunosuppression by looking at say antimetabolites first, etc., in a stepwise manner. Well, what's the mechanism? Is there a biological explanation for lower risk of mortality in patients on tacrolimus? Well, we know that inhibition of viral replication is an immune response. The immunophilins are involved in this process. We know that tacrolimus binds to one of the immunophilin, which is FKB binding protein, which is involved in the process. And by inhibiting calcineurin and suppressing the early phase of T cell activation, this is considered to be one of the reasons why we may actually have a protective effect, because it could mediate or ameliorate the cytokine response. Now, one would expect that to be the case with cyclosporine as well, but the reason it doesn't happen is because there is a differential action of tacrolimus as a potent antifibrotic agent in the lung fibrosis compared to that with cyclosporine. So probably that's the mechanism behind. And on the right-hand side panel, we see the evidentiary data from in vitro work, which shows that the replication of SARS viruses are significantly affected or decreased by increasing concentration of tacrolimus. Well, mTORs would do the same. However, it doesn't seem to be showing the similar effect in the liver registry data. One possible explanation for that is that there is potential that the mTORs do have decrease the antiviral barrier, okay, that could potentially be harmful in pathogenic viral infections. So that's probably the mechanism behind understanding the differential effect of tacrolimus. Now, what about the role of vaccines in transplant population? And if you look at overall transplant population, then vaccinated patients who have received 2 doses of mRNA vaccines, either the BioNTech and Moderna or the Moderna vaccines, then even after 2 doses, approximately half the patients do not have measurable antibodies. It is related to age. Again, age plays a role. You can see that here. Ethnicity doesn't play a role, or the gender does not play a role. However, the type of organ transplant does play a role, probably related to the use of or the degree of immunosuppression. And the other key factor which plays a role is the role of antimetabolites. Okay? And we now begin to see that effect of antimetabolites also in non-transplant populations, for example, rheumatoid arthritis, etc., that presence of antimetabolites for the treatment does significantly reduce the risk of of the inactivity of the vaccines. So where do we go from here? Well, in order to understand that if we are going to offset the antimetabolites, say the mycophenolate mofetil or mycophenolic acid, then we need to understand how do we balance the tacrolimus. Now, the best data for minimizing the role of MMF for steroid actually comes from a very old study in 800 patients published by Professor Van Rentigem. And here, patients who were randomized in a double-blind study remained on a triple regimen for the first 3 months, and at the end of 3 months, they were randomized to stop MMF or to stop steroids. And what we see is that in all these patients, the levels of tacrolimus at the end of the dosing, the 90 days, was 10 nanograms per ml, which in today's practice, based on the newer assay or the immunoassay, is equivalent to around 8 nanograms per ml. So you would need to have that levels, and then withdrawing MMF does not affect the immunity or immunological response. So there is no effect on development of histological grade rejection. So, do we need to therefore rethink how we minimize immunosuppression medication? And I go back to thinking, and I was thinking that, well, we need to understand the mechanism. It comes from the 1890 graduation book of John Hopkins, which said that truth will set you free. So we need to understand what the mechanism and our understanding of the different factors are. Well, the most important factor is trying to understand the long-term impact. So this data comes from the CTS registry in Heidelberg, and it's based on over 100,000, over 200,000 patients. And these are all patients. It doesn't necessarily affect only kidney transplantation. But there is a shift, slight shift in patients transplanted before 2000 versus 2000, since 2000. There's a slight flattening of the curve. However, in deceased donor kidney transplantation, even now, if you look at post-2000, then you would lose around 25% of the grafts over a 5-year period. Okay. In liver transplantation is higher, etc. Okay. So what is the mechanism as to why we lose? And that goes back to the work done by Pascal, published back in 2002 in New England Journal of Medicine. And he looked at, hypothesized on the basis of saying there are non-immunological factors, which are donor recipient factors, which we can't do much about. At that time, it was also considered that CNS nephrotoxicity was also a significant factor associated with graft loss. But the immunological factors development, where you had pre-pregnancy, transplantation, or pre-transplantation, etc., with preformed DSA or specific antibodies, but they also looked at the role of non-adherence and suboptimal exposure. But since then, we begin to understand that there is another factor, which is the variability of exposure, the intra-patient variability. And this is emerging data and very well understood and very well documented now. So we will look at both the intra-patient variability and non-adherence as the two modifiable factors and how we can manage those. What is intra-patient variability? Well, it is the tendency for the same dose of CNI to produce different exposure on different occasions within a single patient. Okay? So this is defined as intra-patient variability. And there's loads and loads of publication on the role of intra-patient variability on poor outcome. And these are going from liver transplantation to kidney transplantation to multiple organ to heart, lung, etc. So irrespective of the transplantation, the intra-patient variability or IPV plays a role. Well, the biggest study, however, comes from again from the CTS registry, and this is published by Chana Sousa. And this looked at the database, which had data on more than 96,000 patients transplanted between 2000 and 2014. And of those 6,500 or more patients had levels as well as doses over the period of 3 years period. And so then they looked at the outcome from year 3 to year 6 post-transplant, okay, and the role of intra-patient variability. So we see that as intra-patient variability increased, IPV from 30% to 45%, graft survival decreased, death-centered graft survival also decreased. But what was for the first time more interesting was the patient survival was also affected. So in essence, even in kidney transplantation, losing the graft increased the risk of mortality. And again, in each case, that was significant. Okay, so intra-patient variability is a significant factor. Now, the mechanism behind it goes back to the work done by Rodrigo, and he showed that if you have a cutoff at, say, 30% is a CV, this coefficient variation of the variability, then those who had less than 30 versus more than 30 had a hazard ratio of approximately 3, okay, to develop donor-specific antibodies. Okay? And these are independent factors for development of DSA. Well, what are the different sources of variability? Well, one is non-adherence, potentially, uncontrolled switching, even within bioequivalent formulation, we'll discuss that. Type of drug formulation, and again, formulation does play a role, and we will share that data with you. And genetic polymorphism. And one of the ways to tackle genetic polymorphism is also to tackle the role of developing different type of formulations to overcome or minimize the effect of genetic polymorphism. I will discuss that. So let's look at it. So like all the, like mTORs as well as the other CNI, tacrolimus is a substrate of CYP3A5, CYP3A4, cytokines, cytochromes, as well as P-glycoprotein transporters. Now, the CYP3A5 is present in the proximal small bowel, where the metabolism of this class of drugs takes place. Elimination is driven by P-glycoprotein transporters, and the density of these decreases as we go down the GI tract. And as we go down, we actually eliminate more tacrolimus or more of these products as a function of PGP. Now, which means if we change the way we deliver the drug, either to deliver it higher up or between the proximal and distal small bowel, then you are likely to change the intrapatient variability. Now, how do we manage that? I will show the data. So, if you look at the carriers of CYP3A5, then the CYP3A5 star 1 are regarded as those who are expressors, and these have high metabolic rates and approximately require 50% higher dose. And they also have, therefore, higher intrapatient variability, and we show the data. We have also shown that in the Asian population, we see increased risk of renal graft rejection in patients who have CYP3A5 expression. Now, this is a modifiable factor, is a non-modifiable factor, but we can change its risk by changing the formulation. Okay, and let's look at that. So the ways of looking at it goes back to looking at cyclosporine. This is the development of cyclosporine microemulsion compared to the old formulation, and this delivered the drug as a liquid formulation higher up that changed the way we deliver the drug. You have the immediate release tacrolimus formulation, which releases mainly in the proximal small bowel, therefore it's affected by CYP3A5 metabolism. You have the prolonged release once daily formulation, which delivers the drug in between those areas. And then you have a tablet formulation which releases the drug even longer, but then is subject to P-glycoprotein transporters in the distal small bowel. Therefore, it does not necessarily have the benefit of decreased intrapatient variability. Now, cyclosporine, and this is the data coming from Jan Kovarik. And again, this is very old data, but still explains the mechanism behind the development of the microemulsion formulation. Going from the standard immune to microemulsion significantly decrease the intrapatient variability. Now, this also happens with tacrolimus. This data comes from Professor Wu's group in Taiwan, and he followed the patients for 6 months pre-transplant and several months post-transplant and measured their levels on stable dose and did a coefficient of variation on the exposure. And what you see is that when you move from immediate release to prolonged release tacrolimus from twice daily to once daily, most of the patients move to the left, which means you decrease their intrapatient variability. And you see on the right-hand side panel the individual patients with improved variability. Now, although this difference is significant, what is more interesting is the role of the high and low metabolizers. So the expressor CYP3A5 had a significant decrease in variability. So again, modifying the way you deliver the drug changes the effect of the, or minimizes the effect of the CYP3A5 metabolism. We have also seen this in Caucasian patients, and this work, I was involved in this, and it's a work done by Frank Stift. And here we collected profiles, full pharmacokinetic profiles on 5 different occasions over a 6-week period, converted the patients on 1 milligram per milligram basis from immediate release to prolonged release, and then did another 5 profiles and looked at the variability in terms of the AUC. And we see a significant decrease in intrapatient variability And this is largely driven by the expressors of CYP3A5 Now, let's move to non-adherence. Non-adherence, what does it mean? Well, it's a deviation from prescribed medication regimen. We know that. So what does, there's clinical non-adherence, which results in clinically measurable events, and subclinical, which does not immediately manifest in a clinical, but over the long term, it has impact. Now, if you look at the graft loss, kidney graft loss due to antibody-mediated rejection, then we see that approximately 50% of the antibody-mediated rejection graft losses are related to non-adherent patients. Okay. And the mechanism, again, just like with intrapatient variability, is related to development of specific antibodies. And you see the hazard ratio is approximately 5-fold in non-adherent patients. So over a 12-year period, you have a 5-fold higher risk of developing donor-specific antibodies in non-adherent patients. So does moving from twice daily to once daily change or improve the non-adherence? And the most well-documented study comes from Dirk Kuipers. And this is a Belgium group again, and patients were followed up for 3 months period, and the data was collected electronically using containers which were connected to the computer. So every time the caps was opened, it registered the timing and the duration. And therefore, you can see before conversion and after conversion, and then at day 0, 2/3 were converted to once daily, and we see an improvement, a significant improvement in non-adherence compared to prior to conversion. Then we see also the same thing with liver transplantation. This comes from Sabine Beckerbaum's group, and here we see almost a 50% improvement in taking non-adherence. Time in non-adherence is improved by almost 70%. But there is also the other issue, which we tend to forget, the side effect profile. So side effect can also drive patients to become non-adherent. And this is an elegant study done by Verou et al. From the French group, and they actually looked at rationale. So they said, okay, a number of patients give up or are non-compliant because of the gastrointestinal side effect, abdominal pain, reflux, indigestion, diarrhea, etc. So they therefore measured using what is known as GSPR, gastrointestinal symptom rating scale, and on these factors, and the before and after conversion from prolonged release to immediate release, from immediate release to prolonged release. And this is within patient comparison. You can see there is a significant improvement in the side effect profile. Okay, and this then obviously reduces the risk of non-adherence. So there is another source of variability, and this is related to switching between multiple formulations, even though they are bioequivalent. So let's look at the data. Well, the first one data comes from Schwartz et al. This is from the US group, where you're collecting the information from the US registry data. And what we see here is that patients were followed up for a 3-month period prior, and then over a period of time, they were looked at in terms of patients who remained in a single formulation. This was predominantly the branded formulation, versus those who were changed or whose prescription was changed as and when they came for refills. Okay. Now, this kind of data is only available, can only be collected in the United States, and that's hence the study was done there. And what we see here is that if you look at the tacrolimus trough level to dose ratio, number of trough level measurement, and variability or excursion, then each of them was significantly higher in variable group compared to fixed regimen. And the fixed regimen was predominantly branded patients. Okay, so it's related to fixed rather than brand, never mind. but this is a role played from the from the role of variability of different formulations, which impact the variability. Okay, what about the role of bioequivalence? So we know that for narrowtherapy index drug, the definition is based on comparing population means. Okay, whatever, you know. And one of the reasons why we see those variability is because bioequivalence does not necessarily guarantee exactly the same exposure. Let's look at the data. So the bioequivalence in the European criteria or the Canadian criteria based on a confidence of 90 to 111 for confidence interval 90 to 111 for AUC and 80 to 125 for Cmax. Now it means that if study is repeated 10 times, then 9 times out of 10 the ratio, the mean ratio will lie within that. It does not mean that every single patient is bioequivalent. Let's look at the data. Now here is the data. This comes from cyclosporin, again published by Jan Kovarik. So what we see there is Cmax and AUC, which is peak concentration AUC. It lies, although the mean is within the confidence interval, the individuals are not. They are outside. So a significant number of individuals, almost half in this case, fall outside, both in terms of Cmax and AUC of the acceptance criteria, which is the margins that we talk about. Now, we see the same thing with tacrolimus. Now, this was work done by Ida Robertson, and this is a very well-designed, randomized, prospective crossover study in elderly population, where they went from a branded product to a bioequivalent generic product. And this bioequivalent actually meets the narrow therapeutic index bioequivalence criteria of European Medicine Agency. And we see that if you look at the AUC, the tacrolimus generic to original ratio, that is 70% higher, although the trough levels remain the same. So you can have the same trough level, but the exposure is different. Okay. And we see the same thing occurring in the work done by Momper, and this comes from Professor Verentegam's group in Pittsburgh. And this is approximately over 100 patients with a mean graft age of 100 months. And they defined the variability as being greater than 25% and looked at dose adjustment as well as variability of exposure. And you see that approximately 50% of the patients did have a difference in exposure, which was outside of the confidence interval. So even though the formulations were bioequivalent, okay, there is a difference in exposure when you switch from a brand to generic. It does not mean we should not. It just basically means that it is imperative when we're switching the formulations that the exposure is maintained. Okay. In the first case, there was difference in AUC which did not manifest in trough level. Here we're looking at changes in trough level. So in essence, we really have to be very careful how we switch between formulations under uncontrolled conditions. Okay. What about conversion? Does it have a clinical impact? So it goes back to cyclosporin days compared to cyclosporin microemulsion, and this comes from the data from Tabor et al. Published back in 2005. And we saw that when patients were, when the center was using branded product compared to generic bioequivalent product, then there was more variability and more acute rejection. So more biopsy confirmed acute rejection and more second episodes compared to the cyclosporin microemulsion, which was branded. And again, it was mainly related to variability of exposure, which was higher in the cyclosporin microemulsion generic group versus the equivalent group. Same thing happened. One would think that lightning would not strike twice, but it did. And this is exactly the same thing that happened with tacrolimus. And this is the comparing branded versus the other group. And we see exactly the same thing in terms of looking at patients. Now, these were patient started on 0.1 milligram per kilogram, same dose, same trough level recommendation, and everything else was the same. And the variability was defined as incursion above 20%. And yes, in essence, we see the same thing here. We see that if you look at the generic formulation, then compared to branded, then you had more variability, and this led to increase in annualized rejection rate, as well as more patients with antibody-mediated rejection. So there is a risk associated with that. So does this mean maintaining patients on once a daily formulation has any clinical benefit? Okay, so this is the what we call the elephant in the room question, and we go back to understanding the long-term renal function in transplant population. We know that over a period of time there is cumulative incidence of chronic renal failure occurs as a function of the different types of transplant patients. Now these data exist from Ojo et al. For a long time. Notice that at the time of this tacrolimus was not a product which was approved when it started in 1990. So majority, almost all the patients here are non-tacrolimus based therapy patients. Now, but if we start to look at tacrolimus based patients, then we look at the impact of the mean GFR, then we see the conversion from immediate to prolonged release tacrolimus did improve the GFR. Okay, we see an increase in GFR in kidney transplant patients here. Now, the biggest study comes from Girardo et al. This was one of the multi-center study in about 1,800 patients. Patients who were converted from immediate release to prolonged release tacrolimus on 1 milligram per milligram basis. And then they followed up the patient both in terms of the dose and there's a slight increase in dose required. However, the trough level size decreased. But if you then look at the long-term data over a 3-year period, see the milligram per kilogram in essence does not significantly decrease compared to pre-transplant 3.9 versus 3.8. And the trough levels were between 7.2 minus 6 months to 6.7, slight decrease over that period of time. But what is interesting was that if you start looking at the dose normalized concentration, then the dose normalized concentration more or less remained the same between 2.5, 2.4 ratio to 2.3 ratio. But what did change was the variability. So compared to pre-conversion, significantly more patients had reduced intrapatient variability, moving from twice daily to once daily tacrolimus. And this also led to slight improvement in eGFR, okay, both measured as MDRD, okay, with patient reinitiation dialysis set to 0 and not set to 0. And in essence, what we see is that you have an improvement of about 0.47 mil per minute in terms of the eGFR. One would expect to see same or slight decrease, but actually you get a stabilization or improvement of eGFR with once daily. Now, we see the same thing in terms of the graft patient survival. This comes from liver transplant data, however, from the ELTR registry. This is looking at between 2008 and 2016, and therefore this represents the branded once daily tacrolimus. And we see at 4-year, there was a 5% higher graft survival in liver transplant patients comparing twice daily versus once daily tacrolimus. We also begin to see the role of long-term data in terms of eGFR. So here we see an eGFR in patients in liver transplant patients over a 5-year period. And this is one of the biggest study done in the Diamond study. If you compare eGFR over time, measuring renal function, that it remains consistent over a 5-year period. Rather than decrease, it is actually maintained flat. Now, we come towards the end of the presentation, and let's look at the role of the prolonged release tacrolimus with the inclusion of MMF or inclusion of mTOR. Now, here this is inclusion of MMF, prolonged release tacrolimus plus steroids, and here's decrease of tacrolimus dose by about 25%, prolonged release tacrolimus, but decreasing with the addition of sirolimus. Okay, now let's look at what happens to renal function over time. And essentially what we see is this is actually measured rather than calculated, estimated, and then measured by IOXOR. There is no difference in renal function between between the MMF group or the reduced tacrolimus and plus sirolimus group. No significant difference between the two. And interestingly, 5-year data also does not show a decline in renal function. This is we begin to see the benefits of once daily tacrolimus over a long-term period. So the eGFR is maintained; it does not decline over time. And the graft survival is on the right-hand side. So, in summary, what we have discussed up to now is that tacrolimus is a core component of immunosuppressive therapy. It is recognized as a narrow therapeutic index medication. Impaired immunity is a risk factor for clinical outcome in transplant patients with COVID-19. Protective role of tacrolimus has been observed in liver transplant recipients, and again, we now begin to understand also from non-transplant indication that it is the role of antimetabolite which affects the antibody response to 2 doses of mRNA vaccines. The data from the non-mRNA vaccines, for example, the Johnson & Johnson and AstraZeneca, also suggest actually even lower response rates. That data is published but not covered here. So we need to consider the role of antimetabolites in that. Maintaining long-term graft survival is a challenge in both kidney and liver transplantation. Interpatient variability is associated with one of the variables associated with poor long-term graft survival. Non-adherence also plays a role, and we know that genetic polymorphism now is well understood as a covariate for intrapatient variability. And switching between formulations, even those meeting bioequivalence criteria, leads to significant variability in systemic exposure. Tacrolimus prolonged release formulation has demonstrated improved intrapatient variability as well as improved adherence, and we're now beginning to see that long-term data from looking at 5-year data shows both an improved graft survival as well as improved renal function or significantly stable renal function compared to immediate release twice daily formulation of tacrolimus. With that, I say Dhanyavad, thank you very much. And just to point out that please refer to your respective prescribing information for both twice daily as well as once daily formulations. Thank you.
Thank you, sir. That was really insightful and enlightening talk addressing various pharmacokinetic as well as clinical aspects of tacrolimus, both the immediate release as well as long term, as expected from a person like you. Since we have few minutes left, is it okay if I raise a couple of questions I would like to highlight, or would you, which I would like to clarify with you?
Yes, please.
Thank you. You were saying, no, we do the issue with conversion between brands is okay, but in a place like India, where the most common, I would say 90% of the people will be on generic forms of tacrolimus. These are not the original for various reasons. So how do we deal with that situation when the original brand is not widely used? It may not be an issue with, what are the issues with this sort of preparations?
Yeah. Okay. So go back to, for me, it's not purely an issue of branded versus non-branded. Okay. It is an issue of switching between formulations, irrespective whether they're branded or not branded. Let me go back and say, for example, warfarin, okay, or digoxin. Whenever we change digoxin or warfarin, we actually do some kind of a measurement. Okay, so we would do INR measurement, one warfarin. We would look at other parameters with digoxin, and exactly what we would do with flecainide, etc. Now, so this is exactly what we would do with tacrolimus or cyclosporine. The issue is not saying that we cannot convert. The issue is, if we convert, how do we ensure that the bioequivalent product still has the same exposure between individuals? So you could have two generics which will not be bioequivalent to each other. And even if they are bioequivalent, they will still not be interchangeable. So the difference is, you can have two bioequivalent formulations, but will not be interchangeable because they will not have the same exposure. So I recommend, in essence, that if we are going to change between formulation, and then every time we have a change in formulation, we do exactly what we do with warfarin. We actually measure something. And in case of tacrolimus, we would suggest to measure either the AUC, which is limited sampling area and constant. So you could do 3 sample AUC or 4 sample AUC over a period of time, or we do at least trough level measurement on more than 3 occasions, and we compare mean exposure prior to conversion to post conversion. Okay. And this is important because you could have completely bioequivalent product which will have 10% difference, 15% difference in exposure. And a 15% difference exposure with tacrolimus is huge in terms of the outcome for the patient. So my recommendation is that I would try and keep the patients on as much as possible on a single formulation. So, but if we do want to change, no problem, but then they have to be monitored. And, and bring the patient in on a routine basis at least 3 times. And this is what we do in Europe. Now, for me, that is not a luxury. I know sometimes people say, okay, in Europe, you can do that because somebody is paying for the conversion. Yeah, but it's not a luxury. It is a necessity to monitor.
I understand. So I was looking at the data you presented. It seems that even though the trough levels may be similar, the peak levels, the Cmax may be different, yeah. And that, I suppose, would explain some difference in the adverse effects we see when we change brands and we have the same trough levels.
Yes, absolutely, absolutely, and we saw exactly the same thing. And some of them do not manifest immediately. So we will convert between 2 formulations which meet the bioequivalence criteria. Remember that I'm not sure that, as far as I'm aware, that there are no guidelines for the different guidelines in India for approval of generics on narrotherapy. For example, in Europe, the bioequivalence criteria has to meet a 10% margin, which is 90 to 111. So you have to have an even stronger proof for bioequivalence in Europe and Canada compared to India. So even within that 10% criteria, we see big differences in exposure. Okay, and therefore we would, you see Cmax will be higher, toxicity will be different, and so we would need to monitor that on a routine basis. It's absolutely essential.
Thank you for that. So the other question which came to my mind was, we do see from time to time people who have very high dose. It's once in a while. But usually if someone needs only, say, 2.5 milligram twice a day of, I'm talking about the immediate release preparation. We have seen at least a couple of patients where even with dose of 8 milligram twice a day or 9 milligram twice a day, the trough levels are not met. So do you think such people may benefit by changing to the adva graph?
Yes. So let me do two stepwise thing. Yes, absolutely. So those who are requiring higher dose of say twice daily tacrolimus, they will. So we do see that they are what is known as high metabolizers. Okay, so they are in general, there will be CYP3A5 expressors or high expressors of ABCB1 gene, which is the P-glycoprotein transporter gene. So these patients, just like, say, African American patients who are high expressors of that, will benefit from moving from twice daily to once daily. And we do see significant improvement in those patients in terms of, so those who are, they actually reach steady state earlier with once daily tacrolimus compared to the twice daily tacrolimus. I've published that. I'm a co-author. We published that data as well. So we looked at data from approximately 3,500 patients, okay, and saw that those who are high metabolizers require high doses of immediate release. When they move to prolonged release, they actually achieve their steady state conditions quicker. Okay? And time to steady state and the variability was reduced. Okay, so they will definitely benefit, and it's published. I'm a co-author of that.
Thank you, sir. So I specifically asked this because in otherwise stable patients, when you convert, I think the literature suggests that the dose may require maybe slightly higher than the immediate release preparation with Advagraph.
No. So there is data which suggests that there is approximately 10% requirement based on trough level. But in the study which I presented, Stift et al., okay, in that study we saw a 1% decrease in exposure only. And in that study we actually managed 5 pharmacokinetic profiles. Okay, the AUC only decreased by 1%. Okay, but the trough levels can decrease by up to 8%. Okay, and therefore, one of my recommendation is that rather than switch patient, when we switch those patients and we see a significant decrease, in some patients they will benefit by just looking at the mini AUC. So if you do like 2 or 3 point AUC, then those patients you will see that they do not actually have an exposure; they just may have a lower trough level. And we saw the same thing in the big study, the Girardi study published, in 1,800 patients, that there was over a period of time, the dose normalized trough level did not change, remained the same.
Okay, thank you. There's a couple of quick things. We usually start with, when we do living donor transplant, the immediate release preparation, we start 3 days in advance. So is it any different with Advagraph, or 3 days is sufficient? Does it take?
Yes, absolutely. The half-life of tacrolimus, whether delivered by the immediate release or prolonged release, does not change, which means time to steady state remains the same. So, and there is, I published the data also, which showed that if you start either 1 dose pre-transplant or even 3 doses pre-transplant, then you actually achieve your steady state conditions on day 3. Day 1 post-transplant already you are at the steady state. And therefore, the difference in exposure that you see between immediate release and prolonged disappears as well. So that benefits absolutely superbly in living donor transplantation. By the way, you can also apply that to cadaveric transplantation. I know it's not common in India, but where it is done, we give pre-transplant dose of Advagraph or once daily tacrolimus, just the 1 dose, and that makes a huge difference in exposure.
Thank you. One other thing which you highlighted was the significantly reduced adverse effects of tacrolimus with the prolonged Advagraph compared to the this thing. So one is what explains this? Is it just the pharmacokinetic profile which explains this, because the trough levels are comparable? One other question: does this also reflect with regard to? I think so. I'm just asking for the sake of clarification about the infectious complications also.
Okay, so that's very important, because in the conversion patients, obviously we did not see an increase in infections. Okay, and But what we did see is that in liver transplantation, you see a consistency of exposure. So therefore, overall, you have, in the longer term, fewer chronic rejections or, or fewer deviation. Our feeling is that's largely related to less variability. Okay, so because the variability decreases, we're actually having a better control of the immune suppression. Okay, now there is a paper published from the Dutch group a while ago, which showed that Ton van Gelder was a group in Rotterdam, but now he's moved to Leiden. They showed that those patients who have higher variability, if you don't increase the dose in those patients to increase the trough level to more than 7.5, then they have increased risk of graft loss. Now, what once daily tacrolimus does, it decreases the variability. Therefore, at the same exposure, you have better control of the immune system.
Thank you, sir. That was an absolute pleasure listening to you. Very informative and exhaustive review of literature as well, and hearing it from the horse's mouth. It was indeed a great pleasure hearing you, and thank you for joining us early morning. And I think we are reaching the end of our time. So thanks once again from my friend as well as from our ISOT for your very informative lectures. Thank you.
Thank you very much for very kind support, and have a wonderful Congress as well. I'll join in later. Thank you very much.